You're tuned into the Advocide Health Podcast. We're here to talk about rare diseases, real people, and the ripple effects of change. Stories that move you, guests who challenge the norm, and vibes that keep it real. Hello, everyone, and welcome back to the second episode of the ASH Podcast. My name is Omar, and joining me here is Ali, who you may recall from episode 1. And for today's episode, we'll be placing the spotlight on a very prevalent issue in Canadian healthcare, the family doctor shortage. And yes, I'm sure that this isn't the first time you've heard about it, unfortunately. It's been on the news for quite some time. But hopefully, Ali and I can give you a more nuanced perspective and talk about its connection to the rare disease community and honestly, just how it impacts the general public as well. So I guess the best place to start is just with an overview. So Ali, take the lead.
Yeah, sure. Definitely, I think this is a very prevalent topic and issue that's going on in Canada right now. If you look at sort of the issue in Canada, give a more statistical perspective, I think over 6.5 million people don't have access to a regular family physician. And that number isn't just like a headline. These are real people. There's, seniors managing multiple chronic illnesses, new parents trying to navigate the infant care situation, especially if there's new immigrants or newly immigrants into the country, which Canada has had a lot of recently. It's individuals living with rare, complex, misunderstood conditions who have seemed to really struggle with this situation and find it really hard to figure out how to move forward. And that's coming from a very important national shortage of doctors. And I think I did some research on it, and there's a calculation that roughly Canada needs about 23,000 more family physicians to meet the current demands of this. And I mean, Omar, I'm sure you'd agree this would have a lot of issues regionally as well, right?
Yeah, 100%. Because of the disparities and stuff in Quebec and BC, those shortages, they affect, I think, based on the research, around 18 to 21% of the residents there. Ontario is just a complete disaster at this point, unfortunately, with around 2.5 million without a doctor. I think even some articles say up to 3.5 currently, but rising to 4.4 million by 2026. So it's absolutely insane how just in one province we have such a huge demand. And really, it's affecting even the rural areas as well. Rural residents, they face a lot of significant obstacles, even more than just the urban centers. And oftentimes they have to travel long distances, and because of the lack of continuity and just minimal provider availability, it's just really hard for them to just find a doctor.
Yeah, 100%. And it's not just a logistical issue, right? It's not just I can't get an appointment this week. And speaking of, I've had my own issues with that at times. It's I can't get an appointment. The days I'm free, the days that the family doctor is taken off. And that's a whole other issue let's not get into right away, but maybe we'll talk more about it. But it's a systemic issue. It's a system level barrier. For people with rare diseases, diagnoses can already take 5, 10, 15 years. Not having that consistent, knowledgeable primary care physician or provider means then starting from zero at every clinic, right? So even can you imagine having to go to one family physician? Let's say you went there once, twice over a year, or maybe even over a couple of years. Then you're going to someone else new. All of a sudden, you have to redo your entire history, start from scratch. They know nothing about you. There's no continuity, no baseline, no one who says I've known this patient for years. There's something just off. And patients, probably have many stories where they can't find physicians, right? I don't know if you can think of any, but it's insane.
Yeah, no, it's crazy. And I remember doing our research, there's this one patient story. You just shared it with me recently, and honestly, it took me a few minutes to really just kind of digest that information. I think that article was published somewhere. Do you remember where? Which newspaper? Or
can you remind me the story?
Yeah, it was about Dorothy Lamont, this 96-year-old.
Yeah. I found the article on the New York Post.com.
Okay,
surprised it was in New York, but I think that it is a Canadian story.
Yeah, she's in Nova Scotia, right?
All right. Yeah.
So unfortunately, she had to put an ad to find a family doctor after 3 years without one, and I believe the wait list was like in the 80,000s or something. It's insane. Like, just for someone of that age, like
Let me
God
pull it
knows how
up.
many comorbidities she may have, and then just she was also a teacher. Just having to take those extra steps, spend that extra money to just show that I'm in need. It's just crazy to me. I have
But
no words after that.
yeah, no, let me. I just pulled it up real quick. So like Loki forgot about it.
Yeah.
But yeah, no, 80,000 patient waiting list, and this is someone, and this was like published. I want to see the actual date of the date of the article that I found was published
Mm.
like May 31st, so like less than a month ago. That's like
Oh
10
wow.
days ago, right? And apparently, her ad, like her putting in the ad herself in the Halifax, it's called the Halifax Chronicle Herald. That's an interesting name.
Yeah.
Is in May 23rd. So this is a very recent story. And
That's
she's like,
crazy.
I've been without a physician for nearly 3 years. And that's at that age, at that like, I'm trying to think of the right word, but like at that stage of your life, being without a physician or being for so long is a huge thing,
Mm.
right? And can you imagine if it was like not just a needing of a family physician, needing like a general, someone to just generally go to. If she had like some thing that needed specialized care, and we've discussed it. It's like a maze. It's like trying to find
Mm.
out anything, right? So you get sent to one specialist, then another, then maybe after that, but there's no like coordination. And then sometimes you're misdiagnosed, and more commonly, there's like you could have something more common with like anxiety or chronic fatigue, but there could be rare diseases. And we've had that issue, I think, before when we were doing interviews on,
Yeah.
I don't remember which specific interview or like which specific survivor we were discussing with. Maybe cystinosis, maybe one of the other ones, or maybe it could have been multiple. But
Yeah.
I don't know if you can remember any of them. But
I think the time where it was like family doctor problems was probably with GBS, because you remember the COVID vaccine thing?
yeah.
Yeah, so they had that problem of like, having those side effects. And first point of contact, obviously, a family doctor, right? But for rare disease survivors, we realized that, they spend years being brushed off whenever they come to that point of contact. And I don't remember the name of the guest specifically, but I remember that even for some other rare diseases, there would be people who a decade later would find out through a geneticist that they actually had a metabolic disorder or they had symptoms of a rare disease. And their life could have been so different if they had that family doctor a decade earlier and just telling them that those symptoms are, under the radar, or they're growing and they may have these implications over time. So it's not just, oh, I need a family doctor, but oh, a life-changing events could have been averted if I had that point of contact at the right time, right place. So yeah, it impacts like the general public for sure, and that's the reason why we're advocating for more family doctors. And there's really that huge issue that's going on, but there's also so many marginalized communities like the rare disease community that have been so impacted by it.
Yeah, 100%. And like we see it more and more depending where you are in Canada. I mean, we talked about the rural remote impact like briefly, but like you have those sort of not overpopulated, but like populated urban centers.
Yeah.
Toronto, Vancouver, even Mississauga to some extent, like I think is definitely getting quite
Mississauga's getting way too big, man.
bro, it's too many people. Sorry, I'm going on a tangent, but there's too many people, bro.
Yeah.
That's a whole other discussion that
Yeah,
like
it's
I
a
feel like
different
this is a
discussion, but
rant.
like it's relevant.
Let's
Yeah.
stop there. But like you might eventually find a family doctor if you're persistent, but it also depends on, are you a resident? Are you a citizen? Are you a
Yeah.
new immigrant? Are you a refugee? There's different classifications. I mean, I remember I was volunteering at a family clinic once, and these guys did, I think it was on Saturdays or like every week, or I think one day of the week, probably a Saturday, they used to have walk-ins, right? So you don't have to be, a patient there. You can just walk in and, eventually meet with a family doctor. The line used to be insane. So many people that, don't have, any private insurance or anything like that. They may have, like an OHIP number and have that sort
Right.
of insurance. Otherwise, they may be on a refugee status, and it was just so confusing. And I can't imagine how it would be for them if all I had to do was trying to just write down their information, give them a card, and be like, "Can you fill this out? Give it back to me." They probably had no clue what they were doing, especially if they were new to the country.
Yeah.
And all they're trying to do is, someone's hurt, someone, kid needs to be checked out, something like that, and it's just like we said, like it's this weird maze or this weird, I don't even know what to call it, where access to like a family doctor is just getting more and more scarce. And these people that are immigrants, also even the indigenous communities actually, um,
Mm-hmm.
they face huge inequities in the primary care like access of it. And then, I mean, you agree with me. I think you'd agree with me. Like the level of trust, right? That's another issue. Any
Yeah, no, no. It,
thoughts?
it it works like straight, right in alignment with what you said. Like when it comes to the trust, especially from those marginalized communities, like the indigenous communities or even the rare disease communities, to be to feel safe and respected in the healthcare system is a huge thing. And if you're from a racialized background, like you said, newcomer, refugee, someone who just speaks multiple languages, you might struggle to even get a doctor who takes your concerns seriously. And sometimes it's not even the doctor's fault. It's just that lack of maybe education and training that may prevent them from connecting with their community. A lot of those family doctors may also have that spatial mismatch. Like they may be, from a different province or a different place altogether, but they're coming, to a new community just because of the lack of, supply and demand, all the problems that we have. So they open a clinic here and they just don't know how to connect with the community, and there's the lack of support. So it's a two-way problem. And for rare disease patients, where their symptoms can be very vague and unusual, it's a double-edged sword. They have the problem of one, connecting with those family doctors, and two, actually advocating for their symptoms and their diagnosis, since it's just, not as prevalent as others. So I think we're at a point where we have to really address why this is happening. Like, why is there such a shortage of family physicians in our country, which is considered one of the best resourced healthcare systems in the world? So maybe, Ali, we can talk about a few points.
Yeah, sure. I do want to, after we talk about this, really question whether or not Canada is one of the best researchers, and like what you and
Yeah.
I personally think about it. But speaking of like why this is happening, I think is definitely the biggest, if not the most important question. Like retirement of current family physicians is
Mm,
a huge issue. I think a large a portion of family physicians in the workforce are, aging, or they're just at a point in their life where they feel like, they don't want to work anymore, or they want to spend more time at home, which I understand.
yeah,
But
yeah.
then that causes a lot of people going out of the workforce or out of that career sector, and not as many people coming in.
Mm-hmm.
And I think next, some of the other issues we have is like burnout, right? So a lot of doctors are leaving primary care or reducing their hours because of the like fee for service model, which then forces them to
Mm-hmm.
do
Yeah.
more and more patients. And if they have that model, that model is more or less also used to pay all of their staff, right? So then you have burnout not only for the family doctors themselves, but an entire clinic that may start taking patients at 9 a.m. all the way till 9 p.m. and on a Saturday, because they're doing walk-ins, and that'll generate them more revenue. Or I feel like revenue feels wrong because the healthcare system, and you don't usually talk about it like that, but that is a fact,
Yeah,
right?
yeah.
They're getting paid through that system. So yeah, that becomes just like another issue where everyone working, because of the overflow of like patients and there being such few family physicians, they're all just being
Mm,
like overworked, and then yeah, it just causes like a crash, right? I don't
mm.
know. Let me know what else do you think could it be? Like, there's so many reasons.
No, I agree with that. And even just adding to the burnout point, was something that came to mind was like the administrative burden too, right? There's so many times where like after hours they got to take their work home. They
Yeah,
want to spend time with their families, like you said, but unpaid hours are spent writing notes, writing consults, and like just wrapping up those reports. And even just spending part of their weekend where again it's not paid. So it's just, for them it's like, am I getting paid as much as, the effort I'm putting in? Like is it feasible for me? Is it sustainable for me? And it's a valid reason for anyone in any workforce. If they feel like they're, getting paid the right amount in order to sustain not just themselves, but their families and like other needs that they may have. So that's really what's leading to the retirement. And I remember reading like not just so many articles, but even on like CBC, watching doctors come on radio channels and just breaking down in tears. That used to happen like in the past few months, just talking about, oh, I can't do this anymore. I need to close my business. Because being a family doctor and having your own practice isn't just practicing for the community, but it's also running a business.
Yeah.
It is a business, and paying that overhead, trying to cover all the costs for your staff, for the equipment, even just like the space itself. It deducts a lot. So I encourage everyone to actually look into like not only the family doctor crisis, but also look into like how their overhead distribution is carried out, because then you get a really good idea of like where the costs are coming from and where their needs and concerns are being brought up from. And then the final point, I think, is just the culture in the medical training. So unfortunately, family medicine has become that specialty that is being treated as a default or fallback specialty, and it's often quite undervalued compared to other specialties like surgery or some of the higher competitive ones. If you're in med, you know the acronym ROADS, which stands for those competitive specialties. I think it's radiology, ophthalmology, anesthesiology, and dermatology. I'm not sure if I know the right words, but I'm pretty sure those are the ones. And yeah, it's just family medicine is being pushed back, and it's kind of like a cycle. It's because of the problems we have right now that's pushing away future students from pursuing it, and then there's less doctors coming in, and it's just a constant circle that just keeps going back and forth, and eventually we just have that shortage. So that's kind of where it's come across. And a lot of doctors have also said that it's not just addressing the family doctor shortage by having more med students pursue family medicine, but also for the government, what can we do to retain those family doctors? If they go into family med and then 2-3 years down the road they don't find it sustainable because the systemic problems are still there, then why do you expect them to stay, right? It doesn't really make much sense. So there needs to be solutions in all areas. One, in through the government and actually resolving their concerns at the moment, and then in medical schools trying to show more of a primary care focus to ensure that that is not seen as a fallback specialty, but rather as something that has more opportunity. And at the end of the day, family medicine is complex, it's rewarding, and it's vital. And what I find most amazing about it is that, building those relationships, that longitudinal care that you have, it's about seeing the whole person, not just the disease itself. And I'm sure that marginalized communities like rare disease communities would really appreciate that, since you get to spot those early signs and advocate for those life-changing referrals. Maybe solutions is a good way to really wrap this up. What do you think are some solutions we could think of?
Yeah. Before we go on to solutions, actually, I would say like I think 100% I agree. I'm
Yeah.
just gonna like say from my own perspective too. There
Sure,
has been
yeah,
a time
why
in
not?
my life where I felt like family doctors just do nothing.
Yeah,
Or I felt there was like a field where you don't actually do anything for the patient, you're just referring them. I can
yeah.
gladly say that I have had a misconception about that, and I like after maybe have doing some more research on it and like
Mm-hmm.
actually looking into the field more, I have a lot more respect for them because they really
100%.
are that like first contact for anything that's not like obviously emergent, but
Mm-hmm.
stuff
Mm-hmm.
that you need. Because otherwise, we just going a bit more into the healthcare system. But if you were to go into every problem and go to an emergency room for that, you're waiting there for like 10
Hours,
hours
maybe days, even
for
sometimes.
days, especially if you are not emergent, right? If you're
Yeah.
not something that's like dying right there, and even then sometimes um that is an issue. And so yeah, I think in there's like systemic issues and changing people's perceptions of the field and many other things. So before we go on a very very long conversation about that too, I think I'll move on to solutions.
Yeah.
Or any potential solutions that we could have. I think in granted, we're saying this based on like just a disclaimer to anyone who's actually listening. We're saying this based on like our opinion and some research we've done. Everything, any solution that we do suggest is like it takes some time to work out. It won't be like an instant fix. This is
Mm-hmm.
not an issue that can be fixed easily or quickly. It's going to take a lot of effort and a lot of different things changing. First, you could have like to try to help with the situation, have more like team-based care, right? So instead of one doctor managing, potentially an entire clinic, or if it's a smaller clinic, or multiple like tens of like or 20 patients, have a team that can include nurse practitioners, pharmacists, social workers, maybe even a genetic counselor, or patient navigators. This way you create something that can like work off of each other and lighten the load on everybody. But it's also huge for people with rare diseases who often don't who like often need both medical expertise and help navigating social aspects of their care. I mean, we kind of mentioned how people we've interviewed have been misdiagnosed in the past. And, sure, after a while, they'll get the diagnosis right and they'll find out what's wrong with them. But that's not a fix, right? You still need treatment. You may need, an occupational therapist to help with your daily life, and finding that is not easy because, like you said, if finding a family physician is hard, you think finding an occupational therapist is going to be any easier? Nope. So yeah, that's definitely one of the like biggest solutions I think I could think of. Another one would be just like fixing the way that the system works, so the salary models, or trying to find a different payment system that would reward like the quantity or continuity of work rather than doctors taking multiple patients a day just so that in case that they're trying to earn more to run their clinic, but then they're burnt out, the patients aren't receiving the right care, and their staff is also burnt out. Like, I think that's also why we're seeing a lot more of I don't know how to phrase it, but it's almost like chained clinics. Like, how like fast food restaurants have chains. Like family clinics are now coming out with like chains, right? You have it's almost franchise. That's a better word, I think. I swear I've seen like the same clinic name at like 4 different locations near my house, and it obviously means that okay, this is one name or one brand of clinic that's owned by someone, and then there's a different
multiple places,
family. There's multiple locations, multiple family doctors working there, which also could be a system to use if that helps with lessening the load of the business aspect of it. And family doctors can focus more on their patients. But I think maybe creating a better payment system or salary model for this field would then help with patients getting more time for complex issues, and then especially those living with rare or undiagnosed conditions. I mean, that's just some of them. I'm sure, Omar, you can think of like a couple more solutions.
No, those are the big hitters. Those are the main ones that I think can be easily implemented in the short term. Some of the long-term ones are probably the ones that require more time and effort. And I think a big one is education, obviously, for the medical students. I know that we have clerkships and rotations that involve primary care, and some schools are more focused on primary care. But even like just changing the way med students can kind of craft their path through medical school. So like in those primary care rotations, giving them an opportunity to explore maybe a specific marginalized community. Like, for example, us from ASH, we talk about rare diseases. So what about rare disease care? That could be something that you could offer to medical students. And obviously, you're not going to teach them like all those millions of different syndromes. It's impossible. But also just understanding the lived experiences of how those rare disease survivors feel when it comes to diagnostic delays, system navigation, and just the psychosocial toll that comes with going through the system. So broadening the view of how medical students can kind of go through medical school and explore areas that they feel is worth advocating for is something that we could definitely do. And that involves, working with the curriculum, working with those medical schools, and just being part of those committees that can shape the way medical school is taught is something I would think of. And then finally, like the patients, it's always about the patients, right? So involving them in designing a new primary care system, or at least just reshaping it altogether, that is very important, because people living with rare diseases or from any marginalized community, they are well informed and they can help build something that's more responsive, something that's more flexible, and it actually meets their real needs. So it's not just about creating policies and implementing them over time, but actually seeing how we could pilot test some of those ideas, even within their own communities, just to see if it actually works. Pilot testing is a huge thing that people tend to do, especially for trials and stuff. And, over time, we can just add more and more to it. It's like open access scheduling, digital symptom tracking, or just sharing medical records across providers rather than just keeping it with one. I'm sure that the system already has some of these in place, but it's not just about having them in place, but also involving the community so that way we get feedback and we improve them over time. But yeah, those are mainly all the solutions that we could think of. Like Ali said, it's complete disclaimer, it's based on research, and obviously it takes a lot of time and effort to really put this into action. And I'm sure there are many more ideas that our doctors can think of, but these are just some nuanced perspectives that come to mind.
All right, and I think that brings us like full circle for this episode. But at the end of the day, whether we're talking about rare diseases, advocacy, healthcare reform policy, or anything else we can think of when making an episode or thinking about how to make an episode, it comes down to the fact that this is the topic about people who deserve to be seen, heard, cared for, and family medicine, when it works the way it should, which I think I don't have the best, I can't think of an example of at the top of my head, because I don't know of a perfect system anywhere in this world. You just have to try to make the best of what you can and keep trying to improve it.
Yeah.
But when family medicine does it right, then it does exactly that. It gives people that ability to be cared for.
100%. And I like what you said, that like not everything's perfect. And that's not kind of the expectations that people have to have a perfect system. It's just something that addresses the real problems and not just overshadows them. So that's one thing to note. And if you're listening right now and you've ever felt like dismissed, delayed, or left out of the healthcare conversation, we hear you. We've also gone through many things with our family members, loved ones, going through the ER, trying to contact family doctors, and just being part of that problem and understanding how it feels on the other end. We completely hear you. And the point of these podcasts is to really amplify your voice, amplify those problems, and push for better. That's, even if it just starts with the two of us, at least there's a voice out there that's bringing that into the spotlight.
And realistically, and hopefully you're listening too, but if you're a med school student, policymaker, or because we need them, future family doctors, I think we need that a lot in this country, that, as we mentioned, you guys have the power to change this issue, or at least you have the power to influence change on this issue, potentially more than we do, right? We're trying our best, but hopefully you guys will too.
Yeah, and I'll just say my final goodbyes then. Thanks for tuning in, guys. If this episode moved you or made you think, consider sharing it with someone you care about, or tagging us on social media at Advocate Health. Every listen, every share, every story brings us closer to a healthcare system that potentially works for everyone.
Yeah, and we will keep trying to come up with new episodes, and more things are going to be coming up. Hopefully we'll get some guests on soon. Please hit a follow, stay tuned, and if you really feel that there's something that we missed or a topic that you're passionate about and you think we should try to cover, feel free to reach out on us on our social medias or on our email. But otherwise, thank you guys for listening.